Mark pointed out yesterday that since the time of Richard Nixon, we've been trying to reduce costs. If I remember right, that was about over 40 years ago. So it hasn't happened. They just kept going up and up and up and up and up. Are the opportunities hiding from us? Are there hidden opportunities, or do we know how to reduce costs?
Think about how we would stimulate the curiosity of American doctors, hospitals, and nurses about understanding how those among them, either in this country and ideally outside of this country, for those that are producing the same level of quality at a much lower cost, how are they doing it? And then once that was understood, test its replicability in one's home institution. And the broad term for this in any industry is called translational efficiency. You look around, you look outside of your walls, see who's producing the same good that you are, or service, at a much lower cost, and then take their, if you remember your Economics 1 course, production function, and replicate it here. And for example, one of the things I'm very excited about is there's a graduate student up at UBC, not that far away from us, who's methodically taken, admittedly, one of the most simple types of surgery, eye surgery. He's looked at a hospital in India that is producing that surgery for about $50. It's being produced in British Columbia, which is at a lower cost than we're doing it here, but in British Columbia, the all-in cost, including the surgeons, about $800. And what he's done is he's plugged in to the way in which it's being done in India, the actual labor cost and non-labor costs per unit that are being paid in Canada, and basically computed that you could, if you mimicked, the method of production that's being used in India and getting much better results, by the way, than dramatically lower complication rates than England, which it's been, compared with, you would reduce the cost of cataract surgery up in Vancouver by 85%, taking into account the higher labor cost and higher non-labor cost. And that's opportunity number one. The second opportunity really has to do with how quickly do those who are at the frontier in cost and quality move forward, and I'll let Mark take that one.
Well, I think Arnie gives a great example of the kind of micro practice reengineering that's possible. Our colleagues at Virginia Mason, I've been tremendously impressed over the years, are really at the forefront of saying, how can we do this better? How can we do it more safely? How can we do it more effectively? How can we do it more affordably? But even they and everybody in our system is in some ways sheltered by these macro policy efforts that don't reward that kind of aggressive cost cutting. And so if, for instance, if I were able to do Eyes or Us and capture 60% of the market because I can deliver higher quality surgery at 1/10 the cost, there's a business opportunity for me there. That's why we know the name Toyota. That's how they got to be where they are. But our system is so diffuse and so kind of messed up that those opportunities are often blocked by the incumbents, frankly, who have a variety of ways of making sure that their way of doing things is protected. So we tend to have kind of a silver bullet approach to cost. Depending on our ideology, we think it's greedy drug company executives or fraud and abuse, everybody has a silver bullet. And the fact is, I think, this report that we did suggests, it's lots of things, each of which needs to be tackled. The clinical reengineering that's capable, I believe, of delivering dramatically better quality at dramatically lower cost doesn't happen aggressively unless the reimbursement environment, the policy environment, the scope of practice environment is re-engineered to incent that rather than obstruct it. So I think that's part of why this is so complicated, is there is no one single answer to that.
So, but you seem to imply that, and I've heard Ezekiel Emanuel say, all we have to do is abolish fee-for-service and everything will be fine. Any thoughts on that? Are we saying that it's just the system, and otherwise we'd be great?
No, I want to reinforce what Mark said. Is I think it's not only the incentive system, but also you need to do a little bit to help American doctors and nurses and everybody in the industry understand how to use these tools better. That's not easy to do. If you listen to those who've led lean, either within group health or Virginia Mason, they'll tell you it's not an easy technique to help people to understand and continuously use. What you're doing essentially is saying to people, if you think your job is hard now, which is essentially providing care, now we're going to increase it and say you not only have to provide care, but also reflect on how you're doing it and continuously hypothesize and test better ways of doing it. That's harder, and it's hard to lead. And then the other point Mark made, which is really important, is that if you only change the incentive system, but didn't impact some of the other dials that Mark mentioned, for example, scope of practice laws, you can't replicate the Erevin model here. The Erevin model, I've seen films of what goes on in their operating rooms, and there's not a nurse to be found. And I said, well, where are the nurses? The person who's the CEO of the hospital said, well, for this kind of surgery, once we've taken away the patients who have comorbidities, what would a nurse do? We have ACE, ophthalmic technicians, who support surgeons, and you should really take a look at the film. It's probably on the Erevin website. It's something to behold, where you have a big machine out of the ceiling, which has all the high-tech stuff that the surgeon needs to get the cuts just right, but it's on a swivel. And as the surgeon is finishing up case A, you see out of the side of your vision, the patient is being wheeled in, right while they're finishing up. And the surgeon just swivels this machine and then turns to their left. And it just goes on. And I said, well, gee, what's the world's record for uncomplicated cataracts? One surgeon, 8 hours, one sitting. The answer is 120, which is about the number the average ophthalmologist does in a year. You get a sense of how this could work. Now, they say no surgeon could do this day after day after day, but even if you have them do 80, it's an enormous productivity advantage.
One of the things that you hear is that there's a potential conflict between patient-centered care and cost of care. Do you think people will want to be one of the 120? Is there a trade-off between patient-centered and cost of care, or are the two notions absolutely compatible, one with the other? Mary?
Well, certainly what we found is with patients being more invested in the cost, with the increase in the high deductible health plans and greater cost sharing, they care about the quality and the cost, so that they will be willing to change their kind of patterns. We've seen a decline in utilization rates, as you talked about earlier, in terms of fewer, particularly in the inpatient care and in discretionary services, with greater cost shifting. So I think that they are more willing to evaluate the trade-offs. Maybe not at 120, but certainly they are, they're voting with their feet now with the kind of benefit incentives that they have.
So I remember when Walmart first announced that they were going to be selling a month's worth of generic drugs for $4. And the press release from the Independent Pharmacies of America was, our patients will never go for that. They love us. They love our customer service. They will be loyal to us. Guess who's the #1 pharmacist in America today? So, people are different. There are undoubtedly some people who will want to get their care in a way that they feel comfortable with because they don't like change. They may have plenty of money and they're not price sensitive. But almost every circumstance with which I am familiar, if you can deliver dramatically more affordable service for people, even if it lacks some of the elements of what they thought of with quality, but non-essential elements like assigned seats or meals, people are willing to change. And
I agree with Mark. I mean, there's a film that sort of circulating nationally about a health district in Stockholm that has really excelled relative to all of their areas of Sweden on low total cost of care per person per year and quality. And one of the elements of what they've done is realize that there is a subset of patients who need renal dialysis, who are somewhat younger, who have good technical skills, and who's cognitively intact. And they now have the option of coming in after work and plugging themselves into a dialysis machine. No technicians around. The results are quite good. As Mark said, it's not for everybody, but for a fraction of dialysis patients, you've created the equivalent of an ATM, and obviously the labor costs associated with that are a lot less. It's a great illustration of what Mark was
If you
saying.
think about it, I mean, people are laughing, but you print out your boarding pass at home and you don't think anything about it. And so in healthcare, there are, I think, growing opportunities to promote self-service, self-care, and much of the protocolized care that nurse practitioners, physicians, assistants are able to deliver, frankly, can be delivered by the average well-motivated patient or parent. It is largely our guild mentality that prevents that from happening. Is that going to solve everything in healthcare? No, but it can take off the table a lot of routine, low danger, low intensity stuff that allows the dwindling number of physicians and nurses we need to pay attention to the things that we really need physicians and nurses for, as opposed to having them do routine tasks that technicians or patients themselves can do.
Can I make just an amplification, bring it closer to home? So let's take, Mark said printing off your boarding pass at home. Another option with dialysis, renal dialysis, is renal dialysis at home. You and your family do it. Patients actually feel better because you don't have the yo-yo effect they get when they go in twice a week. They can do it overnight, every night. And what's interesting is even in this country, I was in Canada, roughly, I think about 30% of people do dialysis at home. They don't go in and out of the center. What's important to realize is that on average in the US, people who are able to do dialysis home not only have a better quality of life, but their average annual per capita spending, as best we can risk adjust after taking into account how sick they are, is about 30% lower, because it just, it's a fact. Nobody quite understands why it is, but it turns out it is. Maybe one is a little bit more careful when one is administering to oneself than somebody else. I don't know, but what's interesting is, here in the Northwest, and certainly, for example, California, where I know the statistics, fewer than 5% of patients are getting home dialysis, and most patients aren't even told it's an option. But over in Idaho, 30% of patients are doing dialysis at home, very similar to what's happening in Canada. It's a great example of something where nobody's forcing it on people. People in Idaho, for reasons I'm not sure I fully understand, are given more of a chance to understand what the choices are, and that's favorably impacting health insurance premiums in the state of Idaho, as well as what Uncle Sam is spending, since a lot of those patients are on Medicare.